Our first session is about what is shared care. Yes, we have coordinated this entire convening around shared care, and we still ask this question. So in our first section, we're actually going to define it and really think about how care responsibilities are coordinated among family caregivers, paid caregivers, service providers across different populations. And we hope that this first session will provide a foundation for understanding shared care as a collaborative, what we hear, teamwork, person-centered approach. But I don't want to speak anymore because we have an amazing panel. And I just want to bring out our moderator first, Maddie Sterling. Come on up, Maddie. She is a primary care physician and health services researcher at Weill Cornell, and where she is the director of the Initiative on Home Care Work at Cornell University. And many of you may know her research. It aims to improve health and healthcare delivery for older adults with chronic conditions so that they can remain at home. She is awarded many grants through NHLBI, Doris Duke Foundation, American Heart Association, and many others. We are thrilled that she's here today. And please go ahead and introduce the panel and get started. Just one more housekeeping. We will have about 40 minutes overall, and there will be questions at the end. Thank you.
Awesome. Thanks, Adam. Thanks for having me. So I'm going to introduce up here, or
yep, whatever makes sense for you.
All right. So can I have Dr. Amy Shaw and the other panelists, Lorraine Arcott and Juanita Brown, come up here? Maybe I'll introduce you while you're sitting, and that way people can put a bio to a face. All right. So I'm going to go down. So Dr. Amy Shaw, raise hand. I have the pleasure of working with Amy. Amy is an assistant professor of clinical medicine at Weill Cornell. She is a geriatrician, so I think that is going to be really relevant to this conversation, and directs the inpatient geriatric medicine consult service at Weill Cornell. She interacts with older adults and family caregivers all the time, probably on a daily basis, and is also a member of the vulnerable elder protection team at Cornell, providing inpatient consultation for older adults who experience mistreatment. She's also an educator and trains the current and future geriatric workforce in her fellowship training program. She obtained her MD from University of California, San Francisco, and then she did her undergraduate work at Columbia. Okay, let me keep going. Thank you, Amy. Juanita Brown, raise a hand. Juanita is the founder of the Vinti Circle, a support network for Black daughters caring for the aging or ailing parents. And she's also the founder and CEO of Hey Caregiver, which I happened to look up on the way over this morning. Very cool. An apparel lifestyle brand for caregivers and those who support them. Her caregiving journey began with her mother, and she is now a caregiver for both of her parents. She'll be bringing that perspective to the panel. She's also the inaugural Social Impact Fellow and serves on the Memory and Aging Advisory Board, and also the CMS Expanded HHVP model, which I know some of us are involved in. And she's currently a doctor of public health here at Johns Hopkins. Last but not least, Lorraine Arcott, who's a senior policy analyst at the 1199 SEIU, the largest healthcare worker union in the nation. And she's the founder of Caring Across Maryland, which is here right nearby, an advocacy group for caregivers, direct care workers, and workers and consumer advocacy organizations, who's really committed to improving conditions for the Maryland long-term care workforce. She received her master's in social work from the University of Maryland and her MPH from Johns Hopkins right here at the School of Public Health. Okay, sound like a good group, yes?
Yeah.
Okay, so we have a clinician, caregiver, but also entrepreneur, let's say, and a policy expert. So I think this will give a really nice range of perspectives. I think I'm going to start very broad and ask you don't have to go in a line, we can go out of order, but from your perspective, we just heard from some terrific vignettes from caregivers, but from your perspective, wearing that clinician advocacy and caregiver hats, what does shared care mean to you? And how does it play out for you in the real world and in your community?
Okay.
No, it's not.
Okay.
Good morning, and thank you for having me. I want to start off by saying I am now still just caring for my mom. I lost my dad in February, and we just celebrated his life last Friday. So,
I love you.
yeah, me too. When I think about shared care, I think about what I think his name was Dewan. He said it's community. It's not just, oh, there you are, is that you? Yeah, so exactly, it's community. It's not just one person, but normally it is one person. I do it all for my mom now, both of my parents, but I want to highlight hospice. Hospice is where we see shared care happening. And so it's not a matter of what it is and how can we do it. It's being done. It's just being done late. Why, the question is, how can we take something that's working already and expand it? For example, if you're not familiar with hospice, I'm sure most of you may be, but there is a shared team and the family caregiver is included from the start. So you have therapists, art therapists, you have the social worker, you have the whatever your faith is, you have the doctor, you have the nurse. They call and check up on you. They send you supplies. Like I'm still using supplies for my dad, for my mom. And she doesn't qualify for Medicaid. So everything that we have for her is paid out of pocket. So when we think about shared care, let's think about how we can take what's already working and apply it to a person that is not at end of life, but just want to live a better quality of life. So when we think about shared care, it's more about not just distributing the tasks, it's more about how can we collaborate together.
First of all, so sorry for your loss. But that is, I think, a really rich perspective. I wonder if one of the others wants to talk about what shared care might mean for them.
Yeah, I can share a little bit more. From the Caring Across Maryland perspective and looking at advocacy, one of the first questions we asked ourselves was, what is our shared responsibility to build a more caring future? And I think that question helped us expand that definition of shared care to include our policymakers, to include our elected officials, and everyone who creates the structures of care that impacts the relationship between care workers, family caregivers, and care recipients. And so Caring Across Maryland started in 2022, the year where we would say the pandemic was over, but really a lot of our care workers were still reeling from what had happened. And our home care workers especially were completely neglected from any state support during the pandemic. And they were also the most essential, vital backbone to making sure those individuals that are at home that needed care still got those visits, still got their emotional support, made it to their doctor's appointments. And those are the care workers that the state did not really provide any communication to about PPE, about any sort of support that they might be getting, at least in Maryland, because of the structures that we did not have in place. And so we founded Caring Across Maryland because we understood that if we wanted to build a more caring future and pass legislation and policies that really supported care workers and care recipients in access to care and quality care and good jobs, we needed to build a coalition that saw that shared responsibility and that shared vision to work together. And so we brought together worker organizations, unions, consumer organizations, people that represented older adults, and opened it up to care recipients and family and loved ones as well. And what was really amazing was in that advocacy, I felt like shared care was truly embodied because, for example, we had, and in addition, our advocacy step was across the care continuum. So we advocated for policies in hospitals, in nursing homes, and in home care, which was really important because a lot of our care recipients, they are going through the entire care system and seeing how broken it is. So we would have nursing home workers advocating for home care because they understood that, people needed to be at home and still have that support. We had hospital workers advocating for long-term care workers. We had care recipients advocating for higher wages because they understood that they did not have enough people to come and serve them at home. There was a shortage, and that advocating for higher wages was necessary. And so they saw that interconnection between these policies. We had a member who had intellectual and developmental disabilities who was able to testify in Annapolis because he had his parent and his care team with him to take him to Annapolis and make sure that he was able to testify through his the technology that allowed him to testify. So that just it goes to show that policies can't be changed if there isn't a strong shared care network. Caring Across Maryland really tries to make sure that if we're trying to build a coalition that is for those directly impacted, that our advocacy and policy efforts aren't just isolated and siloed, but it is really embedded in how do relationships work, like how are we building community with each other and making sure that we are caring for each other when capacities come up. We've had a number of our care workers and care recipients say, I have heart surgery, I have, this person just went to the hospital, I can't make it to this meeting. And so we have to kind of be understanding of how all our lived experiences show up in the advocacy space, because it's not going to be sustainable if we aren't able to really see where people are at and what they need. And so I think for us, Caring Across Maryland, we're really expanding shared care to caring for each other in that advocacy, but also inviting legislators and our state to play a role in that.
Yeah. I think what stands out is just all the different sectors and pieces coming together when you talk about shared care. So that's incredible. Let's kick it over to Amy and see if you have a different perspective on what shared care means.
Sure. So, as my perspective as a geriatrician, doing sort of a mix of clinical and non-clinical aspects of academic medicine, I think what I mostly see is all the let's say the wide range of situations that can happen when there are multiple people taking care of an older adult. And so I think shared care at its most basic is just more than one person doing something. But really, when you think of the word shared, the ideal is to think about people working together. And so I think that's how I like to think about it. The other aspect is that as medical professionals, I think we get almost zero training about caregiving or about what this might look like. And so I've seen over the 10 years since finishing residency an increasing number of phone calls and texts from colleagues and friends saying, like, my parents are older, and how do I do this? Or my patient won't take any of her medicines, or how do I get them an aid or something? And sometimes the answer is, I don't know, I'm not sure. If I could solve that problem, I would be more popular. But I think it's just an area that's sort of a blank slate within medicine. So what I'm thinking about a couple of patients that I took care of for a long time who died in the last few years, but had a spouse and also had long-term home care workers caring for them who really worked so well together. It was truly this mesh of respect in all directions that honestly made me just really happy to see them in the office and hear about everything that they were doing together.
That's great. I think you gave a nice example of clinical and then also maybe some workforce gaps and that it hasn't really been in the paradigm for those of us who practice, but maybe hopefully today you'll see it should be. I'm going to You both have also, I'd say all three of you have talked about some things that work well, and maybe I'd like to push each of you to think about when shared care happens for you in your own sort of sector or experience. Maybe talk about some barriers to this, like what are issues that make it hard, and then also some facilitators. So, when it works well, why was that? What were the factors that made it, as Amy just said, sort of gel?
I think it's communication. I'll say one of the biggest barriers is that, especially with family caregivers, we're not at the table. We're not a part of the conversation. We're not a part of the policies that Medicare is making. Like, for example, a hospital bed. Let's just take the basics. A hospital bed. Medicare does not cover a fully electric hospital bed. They only cover the manual, so you have to crank. And if you think about the population of caregivers, most of them are middle-aged. So cranking up a bed every day just to clean your loved one, that's wear and tear on your body, right? So we don't think about, again, I don't know who's making these decisions. If you had a family caregiver, they would say, absolutely not. I've paid, well, my mother has paid twice, an upcharge to get a fully electric bed, because I was like, there is no way I'm going to accept this. But how can we change those? I mean, again, I'm talking just from practical, right?
Yeah, no, I mean, the bed example, I think I spent the last 3 weeks trying to get a bariatric bed covered for a patient and her family caregiver who's a nurse, and we still could not get it done. We got denied twice. So I think that's such a good.
I mean, it's crazy. I mean, barrier creams. Hospice covers barrier creams. That is a leading cause of death, especially in nursing facilities, bed sores. So you go in with something, you pass away, you have a bed sore. Because one, I mean, I could do the whole panel myself. Those are just basics, right? So how do we, and I've seen it in the nurse, when my mom was in a skilled nursing facility after her brainstem stroke, I lived there. Like, I moved in. I had a cot in her room, and I did not leave for an entire month until I got to know the good GNAs. Like, I'm like, who's on tonight? Okay, I could go home and I could take a shower tomorrow. But I remember going to the board and seeing, because they assign you your rooms, one person had 20 rooms. My mother was a total, meaning that she needed total care. There were about 10 of them. How in the world, if you are the best, if you're the best GNA, CNA nurse, how can you provide the care that is necessary? You cannot. It is impossible. They're not paid enough. They are undervalued, under-resourced, and that goes for family caregivers and paid caregivers. You said that you don't have the proper training, nor do we. When I came home, my mom was a teacher, right? And it's not training. They're supposed to train you before the person that you know, it's a demonstration. So they show you how to do it. But when you get home, it looks totally different. So when we talk about shared care, we have to get outside of the clinical setting, go into these homes with the family caregiver and train them. Because I'm very inquisitive. I'm like, okay, but what type of training do you all have? Like the GNAC? So they have a virtual training in Maryland. How, way that you can learn how to care for someone virtually. So there's so much that needs to be done, but I think first and foremost is really having the family caregiver at the table to share what their needs are. And again, sometimes it doesn't happen until they're home. They don't know. You don't know what you don't know until you know that you don't know it. So, it's a lot that needs to be done. Again, I am so grateful for you all, like, shining the light on something that's been needing to change, the policies and, just everything. And so I think that with shared care, we have to think about sustaining the care of the family caregivers and the paid caregivers, like treating them with dignity and respect.
Yeah, Donnie, there's so many issues that are really important. It sounds like on the barrier side, I'm gonna just high level communication, you named. I want to call it policy not matching what's covered for supplies. It sounds like training, big one. So training and preparedness, whether that's before discharge, at home, hands-on training, not just virtual. And then maybe representation and respect are some barriers to this. Okay, great. Really well said. Maybe from one or both of you, maybe where you see things, maybe some other barriers to highlight or some other things or factors that make it go well.
I would. Did I do this right? Okay. All right, I think I did it. Yeah. I was, when you were talking about the hospital bed and the 2 fees, I was also thinking about a little bit of the research that we had done a few years ago that was about heart failure specifically, but some of the aides, the home care workers were telling us that there was a lot of individual variation in how much experience they had and whether they knew whether they were familiar with like the equipment that might be in someone's home or that sort of thing. So I think one barrier is that huge variety of experience and information that people might get from the agency or from somebody's medical team. I think the other barrier that we found in research is also communication based and overlapping with the logistics of a workforce that's sometimes unstable or frequently turning over, where the idea that care needs to be coordinated on an ongoing basis. It's not something you like get trained for once and then everyone just is in a holding pattern. It's such a dynamic process that any issues between the caregivers or between the care recipient and caregivers can get really magnified if there are problems in that arena.
Yeah. And maybe Lorraine, anything from your lens?
Yeah, I just want to highlight what you mentioned about just how the direct care workforce is some of the most lowest paid workers. There's high turnover. We're in a time of unprecedented Medicaid cuts, a rollback of overtime pay and worker rights for home care workers. And it just goes to show the failings of our government and really holding their responsibility to that shared care model of really providing for what workers need and what care recipients need. I think in addition to communication, I think also there's a huge potential for state governments to like step into this equation and take ownership over what does it look like to provide workforce development and training for our home care workers? What does it look like to survey all care recipients and say, what is it that you need? And does our workforce meet those needs? To also make sure that our financing, the provider Medicaid rates are being appropriated properly so that it actually does meet good jobs and quality care. And are we assessing that? Do we have the mechanisms to evaluate that? Because right now we have, in Maryland at least, we have over 2,500 agencies. And I think about 1,200 of those agencies are receiving Medicaid provider reimbursements. And we have no idea what our workforce looks like. We don't know what they need. We don't know what the demographics are. We don't have an idea of what is required to make sure that they are retained and that we can recruit more to actually meet that demand that is growing in the state. And so I just think about some of the structures in place that we need to really support care workers and care recipients more.
Yeah, that actually segues beautifully into sort of the next thought, which is a lot of you have named some current issues and challenges. I think you just offered some policy solutions. And I wonder, I know we're going to have a policy panel, so I don't want to step on toes, but I wonder maybe, Amy, if you could, from the clinical lens, what is it that you might envision would improve this concept of shared care? And then maybe from the family caregiver perspective, we could layer that in.
An interesting question. I think that as clinicians, there's often this feeling to be like, well, these policy issues are so much bigger than me and I can't possibly influence them. And then like a learned helplessness sort of feeling. And so I think that the one important aspect from a clinical perspective is just training people to get comfortable asking questions. I think we often feel that we need to have a definitive answer for something, and I don't think that's necessarily the case. So I noticed that, for example, when I work in the hospital doing geriatrics consults, a lot of the time, I think we just ask more or different questions, and so we get different information. So I've learned to ask people and their caregivers a lot more specific information about what their care needs are and how things are arranged, as well as just more open-ended questions to get the information in a less judgmental or more flexible way. So I think that training people in that way is very important. And I also think that learning about the resources that may be available to us is perhaps even more important than learning like a specific fact, because the landscape of organizations and governmental programs, et cetera, is always changing and is so big. And so I think learning just where to go for that information is really critical. There's a concept in palliative care, which I don't directly practice, but it's sort of part of geriatrics, of what they call primary palliative care, meaning that all medical professionals should have some baseline level of competence with these types of principles. And so I almost think of it that way, that you're not necessarily going to be the one managing the super high level opioids, but you should be comfortable assessing the symptoms and knowing when it needs to be escalated to someone else.
Yeah, so maybe for medical providers, inpatient or ambulatory care, just being sort of primed and ready. I practice in primary care, and I would say that, and as a researcher, I study this, but a lot of my colleagues, right, the caregiver is left in the waiting room, and that just feels like a complete miss. Yeah, I heard the word ridiculous. Yeah. It feels like a miss because I think, as you've just heard, that's whose eyes and ears are on the patient, right? And so to me, that's my best resource right there.
Yeah.
I don't care what condition they have, whether it's a pacemaker or dementia, right? And same thing with the paid caregiver workforce. I think, hearing what's happening at Caring Across Maryland, right? Like, you have workers that are at the ready, and at least in New York City, transporting you to appointments. And so I think clinically figuring out a way, it sounds like, to get providers primed and then make the space for everyone to have a seat at the table. I'll just throw out a barrier. I didn't hear it was time. I think for those of us in the office, this is just a huge, we get 20 minutes. I think geriatrics, you get 40, but it goes. And so I think figuring out a way to kind of bring people together creatively and either prepare or have a series of visits, and we can debate when those get covered and how, but I think just giving people the space and time to contribute is probably another aspect. But yeah, maybe let's hear some other solutions as well.
So your point is, by starting the integration in the beginning, training those who like to be, in the medical profession. With family caregivers, I talked to the social worker when my mom was in neurocritical care, but it was more about where is she going to be placed in a skilled nursing facility. And that was the end of it. She was like, she can go to acute or subacute. And I'm looking like, what is all of this? I worked at Medicare, but I was on the administrative side. So I didn't know all of the terms and the SNFs and everything. But it was like, you don't have anything at all.
And I think, and I think the data shows that anecdotally, right, like, all that gets thrown in your face at the exact worst time you're ready to receive it, right?
Yeah, and it's just very overwhelming. And so through the Venti Circle, which is my organization for Black daughters caring for their parents, that's shared care, that's community. We're able to support each other along this caregiving journey, whether you're just starting or you're on the other side of it. And I think when you have me, I want to position the Venti Circle as a resource for families in those positions because you don't know, you're not prepared at all, right? So starting everybody off with something, resources are needed. There are no resources, there's no handbook. When you're preparing for your baby, there's so much for you to have. I mean, of course, it's not just one size fits all. However, you have a lot of resources to, you have your baby shower, you have your friends, your mom, your grandma, everybody telling you what it's going to be like. And you don't have that with your family caregiver. It happens. And so what do we do? And to your point about the time, when you were talking, I thought about hospice. Nobody ever rushed me off the phone. Nobody ever rushed anything. They had time. Are you okay? Calling every day almost about, do you need a social worker? Do you need this? Do you need that? Oh, we're here for you. Call us 24/7. My dad was at the end of life. Why can't we have that? When my mom was discharged home, I didn't have anybody to call 24/7. I didn't have anybody to check on me. So let's have these conversations early. Let's start early, everybody.
Yeah, I think for those in the sort of, I guess, palliative or, this concept of advanced care planning, but maybe sounds like moving it upstream,
Yes,
right?
If possible. I don't know who's going to pay for it. We might have to pay for it ourselves. But I think that's when we talk about it. Let's think about how we can be creative and make it happen. I have an idea that I want to work with students. There are high schools. I'm from Baltimore. There are high schools in Baltimore that have nursing programs. How can we tap into these kids and have them, work with them to get their hours or whatever, train them to train family caregivers, same with retired nurses and, doctors and GNAs. How can we just create our own community somehow to fund it some kind of way? I mean, we have money for so many. I think I'm taking time, but I'm just going to say this. I'm from Baltimore City, born and raised, right? I don't know how many youth organizations there are, how many PRPs, psychiatric rehabilitation programs there are for, drug addiction. Don't get me wrong, those are important, but we are funneling a lot of money into those things that are systemically created. We know that there is not going to be, there's no solution, right? But we know with aging it's inevitable. Everybody's going to get old unless you die young, right? So we hope we are going to age. And then with that, because of the demographic shift, where in a couple of years there'll be more seniors than teenagers ever in history, how are we not supporting the people who support and care for them? I don't understand, but we're going to pray that a miracle is going to happen. Melinda and Mackenzie and folks out there finding a whole bunch. So we want to make sure that aging and caregiving are at the top, right, of the priorities. Even at Hopkins, a student at Hopkins, aging and caregiving is not one of the 5 focus areas of the Bloomberg American Health Initiative. So I'll just leave that.
I love that. Some local call outs and some national cries for this crisis. Maybe Lorraine, from your perspective, any solutions?
Yeah, I think one barrier that I think kind of sums up what is being talked about at this panel is political will to make it a priority, right? And so I think I don't want to talk too much about the policy because I know there's a whole panel on it, so I'm not gonna, even though I could talk for ages about that. But I think one of the important things is the power of building coalitions. So I see that there's a lot of researchers in the room and care workers. And I just, from personal experience, the stories that are brought to legislators when it comes from a broad coalition is so much more powerful than when it comes from one siloed group. And so in addition to all of the questions that I talked about earlier that our state governments could be thinking about and implementing to uplift our care economy and our care infrastructure, I do think that one thing that is necessary is all of us to really come together and build strong coalitions that have consumer groups, worker groups, researchers coming together that were asking those questions about how do we change the narrative that is taking place. And something that is often said in our coalition, because a care worker, Vivian Boone, who's here today, always says, and to legislators to their faces, one day you are going to age and one day you are going to need help. And that has often been something that has helped legislators be like, oh yeah, like this isn't just some like bill or legislation. This is like real life. And especially a legislator who hasn't maybe experienced long-term care or maybe hasn't dealt with that in their personal life, we've seen it's important that these stories get to them and that people make it to their state capital to testify and share their stories, and that they're working in coalition with other groups that can amplify stories, even if you can't make it to Annapolis. There's so many different ways to change the narrative through media, through working with press, with doing events that are about public education. So I think there's a lot of potential for people in this room to think about solutions, but think about it in working in coalition so that our efforts are collaborative and that we truly build a care economy where we can all just truly thrive in an age and dignity. And so, yeah, I would say that would be one of my big solutions that I would leave the room with.
No, that's great. I'm being mindful of time, and I want to set the precedent of keeping us on pace.
You have 7 minutes after that to Q&A. Yes.
Okay, great. So before we get into the Q&A, I just clearly you can see why these women were chosen for their expertise. But I wonder, since we have panels coming up, if each of you could just say one thing that you would hope to learn today, or one thing that you hope other panelists talk about related to shared care, just to kind of give them maybe something to chew on as we get into the day.
Well, it's hard to say one. One thing that I would like to hear more about is perspectives from the direct care workers and advocacy groups about what direction things could go and what would really be helpful from their perspective, because I usually have my hands full during the visit and there's so much going on. So the focus on just the caregiving part, I'm really excited about.
I'd like to learn how we can really work together, like not it be an idea, but actual practical ways that we can start making it really happen.
I see that there's a lot of panelists from all across the country. And so I think I'm really excited about how do we build this movement across the nation and support each other in changing policy together. So like figuring out what did work. And oftentimes when I'm in spaces in policy that talk about one specific state, there's so many other factors involved, like political will and the person, the legislator that just might have had this special pull to the issue. But like, I think that by working across the nation and in collaboration with each other, we're able to really push our own agendas forward in our own locales. So that's what I'm really looking forward to.
All right, great. I'm going to take us into some Q&A and get everyone up and moving. I see microphones up, and is that the intention that people
Yes.
come up?
One can find the mic to use.
Whatever people prefer.
Great.
Raise
So-
your hand, or come on up, Mike.
Thank you very much. Fantastic panel, great way to start the day. So glad that I made the trip here. I am a doctoral student. My name is Nick Mirren. I'm a doctoral student at Brandeis University. And I study family caregiving, aging, older adults, complex health needs. And I was really struck by how prominent training was as a topic in this panel conversation. And it made me wonder, since there are so many elements to navigating the system as a novice, somebody who hasn't dealt with long-term care in their personal life previously, and there's so much terminology and logistical work, there's so much to focus on with training. I wonder at what point in the caregiving journey would be the most effective to start delivering that training, and what specific subject matter might be focused on in the training. Since there is so much to take in, I'm curious what the panel thinks about the design of training approaches. And, you know, hospice it's wonderful. It offers lots of additional supports, but I wonder also the emotional weight of the caregiving journey. If you start talking about end of life early on, if that could also have adverse effects on the morale and the psychological reserves of the caregiving dyad. So I'd love to hear more thoughts on that. Thanks so much.
That was loaded, Nick. So I'm not trying to see if I can remember. Okay, training. I feel like it can happen whenever.
And what?
So when, right? I'm a certified caregiving consultant, and we learned the 6 stages of caregiving. So it's like the anticipation. Do you think, do you see signs? You're like, oh, my parents are aging, so that's when you can just start learning about how to prepare to become a caregiver. Now, it's hard for me, it was sudden. Like I cared for my grandmother, I cared for my dad when they were both diagnosed. So my grandmother was diagnosed with stage 4 lung cancer. My father was diagnosed with multiple myeloma. So at that time, I did not identify as a caregiver. So I think just from a broad perspective, we could just tell people, train folks on what is a caregiver. If you're running to the grocery store, if you're picking up medication, you are a caregiver, right? So as far as the training, it would all also depend on what the person's diagnosis is, right? So for Alzheimer's, dementia, there are tons and tons of information out there. You kind of know where you are, so you can take those types of trainings that you may need. For me, my mom is bedbound, so I needed to learn how to clean her, how to change her, what a chuck is, how to put it under, you have the draw sheet, how to pull. You understand? So you can't say what, when. It depends on what is happening. The hospice piece, I worked with the end-of-life doula because I saw that my dad was transitioning. And so what could have been, this is the thing, and I think that we all have to understand we're all going to die, right? It's just a matter of, it's not if, it's when, and how do we prepare for it? Me, I'm okay with it. Like, as long as God doesn't take me while my mom is still alive, I'm okay. But if he's ready after that, I'm like, okay, I'm your girl. But with my dad, with the end of life doula, it was so beautiful because I saw the transition. I called on her and I worked with her and we talked about it. I knew what his end of life wishes were and I was able to honor them. And if we look at death as a beautiful part of life, just like we do birth. You think about it, you're so excited and happy when a baby is born, and it is crazy in this world, right? But we happy when they're born, but when somebody dies, we're mourning and all. And I think that if we start talking about end of life and maybe getting people okay with understanding that it is a part of life, then we're able to look at it differently. My dad's celebration was a celebration. We had fun. My best friend is a stand-up comedian. She was the host. So it was like, we have to look at it. We have to celebrate life and not mourn death. So we can talk about and prepare people with end-of-life doula and, early on so that when the time comes, it's not a sad occasion, if you will. Of course, I grieve all the time. Like I just find myself crying at any given moment. But at the same time, I know that I honored his wishes. I know that we did all we could do in terms of his care and the health, keeping him as healthy as possible until it was time. So I think to answer just from a high level perspective, there is no one way to say you need this at this time. We know that from, just from a really grand perspective that we need to understand what caregiving is and just define it as such so people know how to just navigate the journey, because there's so many, it's not just straight line for caregiving. I mean, it's just a whole lot. So I hope that helps, and I'll give you my card and we can sign it.
Yeah, another, great question, great answer. Another question?
Hey, good morning. My name is Josh Lewis. Thank you so much for taking the time to be on this panel today. I work for a Medicare Guide Model participant company, so we focus on care management and respite care for caregivers. My question is just centered around real-world evidence around caregiving and outcomes. I work with 75 different adult day programs in California and home care agencies, so we probably have thousands of caregivers that are in our partnerships. So I'm just curious, it's hard for me to measure outcomes and who's doing a good job, especially when there's different languages and different availabilities. So like overlaying capacity for like an agency with outcomes is like really hard for me to figure out who I should be giving a referral to. So I'm just curious, what do you guys think about outcomes and measuring? Because there's no star ratings in this area. So we'd love to hear your thoughts on that.
I'll be very brief because I actually think it's a great question, and people will often ask me like, well, which agency should I pick? And like, I have no idea. I do think that sometimes I'll hear from people that largely going back to the communication issue, that they either find it easy to communicate with their agency or they find it very difficult. And so on a like one-on-one anecdotal level, I think the level of communication is probably most important, but I think for outcomes it's very hard to know as an individual. I don't know.
Yeah, I can add on a little bit to that. Did you want to?
No, please.
Okay. I think it begs the question about like, how are we overseeing our agencies? And I laugh just because in Maryland we have so many agencies, and that the state does just the very minimum for overseeing them. They just kind of license them, and that's it. There's no other communication with the state and the agency after that. So it's a really important question, because I think that's what we should be moving towards, is like trying to hold facilities and agencies accountable to providing quality care. I know something that we are working towards in Maryland is a home care registry model that helps list out all of the home care workers and the different types of skills, languages spoken, specific trainings that they might have for specific populations, like they have a training for dementia and Alzheimer's, noting that so that when patients are trying to find care, they have something to look towards to figure out if this person meets their needs. Because I think in our current setup of agencies, it's very hard to tell which agency is good, right? And I think there's a lot more work for us to do to get to a point where we have more standards and quality benchmarks for our agencies. But I think something to work towards is making sure people have choice in the care that they're receiving.
Wonderful. Well, thank you so much. I want to thank the panel. We could listen to them all day. We do have 4 other sessions.